topic, which is the neonatal pneumonia. The problem with neonatal pneumonia of this topic is that you heard many things, because you heard respiratory distress syndrome, you heard neonatal sepsis, you heard the management, you heard about a lot of other things in infection. So how to differentiate it, and what is new in neonatal pneumonia other than that? I try my humble effort to give you some extra knowledge beyond those topic which I just mentioned. So first of all, introduction, the pneumonia is an inflammatory pulmonary process. It's an inflammatory pulmonary process that may originate in the lung or to be a focal complication of a contagious or systemic inflammatory process. So first of all, we have to understand the RDS is mostly the deficiency of surfactant, which can alter our structure of our alveoli. But the pneumonia is infectious process and inflammatory process. So the abnormalities of airway patency as well as alveolar ventilation and perfusion occur frequently during various mechanisms, okay? So the derangements often significantly alter gas exchange, and it can lead to organ failure, or it can lead to the hypoxaemia in early stages. Now, as you can see, the definition, as I just told you, is an inflammatory condition of the lung. It is caused by the infection, mostly the viruses or the bacteria, and some less common organisms like chlamydia, mycoplasma, or such other conditions like autoimmune disease. So autoimmune disease is not the infectious process, but the inflammatory process, and can cause the lung damage. The such pathological problems superimposed on the underlying difficulties associated with transition from intrauterine or to extrauterine life. It can cause the critical challenge to the immature human organism. So, So this is the whole thing which we have to understand, and we can differentiate it from the this one is the RDS. So if you ask me how to define, just 1 minute, okay. So how to have a definition of the neonatal pneumonia? Then there are 4 things plus initial thing. So the initial thing is the neonate with respiratory distress. Any of those, rapid, noisy, or difficult breathing, respiratory rate 60 per minute or above, retractions may be, cough is, some studies shows that the newborn can have cough or cough-like symptom, and the grunting. So this in premature, we don't have the cough reflex fully developed. So this is for the mostly for the 37 weeker and above. So initially you have to have those things, plus can be a positive blood culture or any 2 of the following. Predisposing factor: maternal fever, foul smelling liquor, prolonged rupture of the membranes, clinical pictures of the sepsis, poor feeding, lethargy, poor reflexes, abdominal distension, radiograph suggestive of pneumonia. We will talk about that. Positive sepsis screen, any of the following: bands more than 20% of leukocyte count of reference age, the race C reactive protein, and the race procalcitonin. I always ask my junior colleagues, medical students, the fellows who are in training, that please look into the slides. And many times when I ask, what do you understand by the bands, they don't know. Bands are the immature leukocytes, immature cells, okay? And how it looks like and why it called bands. So it looks like this, like a air band when you have a, like your headphones or like thing, the two lobule nucleus. Mostly the neutrophils, the mature neutrophils are the trilobulate or the four lobules. So that's it's called band. And if it is more than 20%, it means the utilizations of the leukocytes increase and the production is delayed and we have an immature cell in our system. So please give some attention to all these minute things. Look at the epidemiology. Epidemiology is very depressing, especially if we are belongs to the developing world. In 2008, there's a big epidemiological survey and the study published, and they said there's 156 million children suffer from pneumonia from any age group. But look at that, 151 million in the developing world and 5 million in the developed world. So you can imagine this is our real problem of our setups. Many of these deaths occur in the newborn period. The WHO estimate 1 in 3 newborn infant deaths is due to pneumonia. The neonatal pneumonia range from 20 to 32% of the live born and from 15 to 38% of stillborn infants. So it's a huge problem for us. If you see the 2018 published study, 41% of the 5.3 million deaths of children under 5 years of age were due to the infection. And the pneumonia is a big chunk of that out of the neonatal period, but the pneumonia is a big chunk of that is 12%. And of course, diarrhea is the highest, but it's a big chunk is the pneumonia also. And neonatal infection, which is the 11%, which is of course, the pneumonia is included in that. Now, what type of pneumonia, what we are talking about? If you see the morphologically, it is lobar pneumonia, bronchopneumonia, or interstitial pneumonia. If you talk about the onset, then we have to know that is the true congenital pneumonia, intrapartum pneumonia, postnatal pneumonia. We will go through this. And etiological wise, the viral, bacterial, mycoplasma, or aspiration pneumonia. So these are the three main categories of the pneumonia. The risk factors, you can get it from anything what you learn in the sepsis lectures by Professor Huck, beautifully explained, and many other talks what we did already. All those risk factors can be applied to the neonatal pneumonia also. So the unexplained preterm labor to gestational history of illness consistent with an organism known to have a transplacental pathogenic potential, all in between, it can be the risk factor. But the important thing which I want to tell you, oh, sorry, why is it going, is this. When the OBGYN tell you that there is a fever, there are three categories you should know. It is isolated maternal fever. It means documented. What is the meaning of documented maternal fever? It means that maternal oral temperature more than 39.0 degrees centigrade, which is equal to 102.2 degree Fahrenheit, I don't know, whatever you are using, on any one occasion is called documented fever. If the oral temperature is more than 38 but less than 39, repeat the measurement in 30 minutes. If the repeat value remain more than 38, it is again the documented fever. So this we have to know about what is the meaning of documented fever. Now the suspected triple one, the triple one and triple one is the classification that is the infection, inflammation, and the fever in the mother. So if you suspected the chorioamnitis, which is equal to chorioamnitis, then you have to have these things: fever without a clear source plus any of the following. And fever, we know that this is the what is the meaning of documented fever. Plus baseline fetal tachycardia by the CTG more than 160 beats per minute. Maternal WBC is more than 15,000 in the absence of antenatal steroids, because antenatal steroid can get the leukemia reaction. Definite, or if you have a definite purulent fluid from the cervical os. The confirmed classification is all of the above plus amniocentesis if they have it, or a low glucose or positive amniotic fluid culture, and later supported by placental pathology revealing diagnostic features of infection. That much as a neonatologist, as a pediatrician, we should know about the maternal chorioamnitis, because we cannot say, oh, there is a fever and there's only 37.8 once a spike. So this is very important table for our learning. Etiology can be anything from congenital pneumonia, maybe infectious or non-infectious, as we just discussed, it from the group B streptococcus to the E. coli to the enterococcus and everything, it can be the possibility. Non-infectious pneumonia can include the diffuse alveolar damage, organizing pneumonia. Anybody know what is the organizing pneumonia? Anyway, in the discussion, we will discuss about that. Non-specific interstitial pneumonia, lymphocytic interstitial pneumonia, desquamative interstitial pneumonia, or aspiration pneumonia. All these can lead to the pneumonia in a newborn period. Timing of onset is again divided similarly as in the sepsis. For example, early onset pneumonia is a variable defined as within 48 hours to 6 days of birth, similar like late onset or early onset sepsis, and the late onset pneumonia is generally defined as the onset of symptoms at more than 7 days of age. And similarity continue in the causation also. So less than 7 days is the same GBS, E. coli, staph, listeria, enterococcus, uropilus, the plasma, late onset E. coli, staph, klebsiella, and pseudomonas. So this is the similar classification timing as we learned in the neonatal sepsis. So we have to remember this a little bit, this schematically. The timing of transmission, let me see the pointer if I have it. Okay. So the timing of the transmission, then the route of infection, then the time of presentation, and the examples. So if a congenital infection in utero, it can be transplacental at birth of or months, year later, it can be viral or the others like torch infection. Neonatal infection, I think this pointer is not working. That's fine. So, I have to remove it. Okay. So the neonatal infection is shortly before delivery, then transplacental. We will go through it, and these are the bacteria, viral, fungal, or later infection with this can be the HIV, hepatitis, all these things. Now come to the pathophysiology. So the pneumonia that becomes clinical evident within 24 hours of the birth may originate at 3 different times, as we discussed initially. It can be the true congenital pneumonia, intrapartum pneumonia, or the postnatal pneumonia. So this is the 3 main classification, and we will go through each of them. So the true congenital pneumonia can be spread by the hematogenous, ascending, and aspiration. Hematogenous means mom with bacteria or viral organism, microorganism is accumulate in the blood and it go directly through the placenta to the baby. Ascending infection from the birth canal, aspiration of infected inflamed amniotic fluid. Intrapartum through the birth canal during the passage of delivery, it may be acquired same like a hematogenous or ascending transmission from aspiration of infected or contaminated materials, fluids, or from mechanical or ischemic disruption can cause all this pneumonia. So these are the true congenital and intrapartum pneumonia. The postnatal pneumonia, which occurs mostly after 24 hours of the life, colonization of mucoepithelial surface with an appropriate pathogen, and the frequent use of antibiotic can disrupt this in the mothers, can disrupt this colonization by resistance organism of unusual pathogenicity. So that can cause the later, which we call the postnatal pneumonia. Invasive therapies typically required in these infants often allow microbes accelerated and into the deep structure that ordinarily are not easily accessible. And the enteral feeding and the indwelling catheters all can lead to those bacteria to be flourished and can cause this pneumonia. So there are three main things, or the way we get the pneumonia is the true congenital, intrapartum, and postnatal. So what will happen? The bacteria somehow reach the baby, and the failure of protective pulmonary mechanism. You know that in the newborn life or in the early prematurity, the mucociliary system is not that developed. Plus, the immunological system is not that developed. So it is the first thing. Then due to this, it infiltration of those organisms in pulmonary parenchyma, which cause impaired alveolar ventilation. Ventilation means retention of carbon dioxide, and cause hypoxia, increased carbon dioxide in the body due to increased AA gradient. How you calculate the AA gradient? You should know it is the PaO2, the partial pressure of alveolar oxygen minus the partial pressure of arterial oxygen. Partial pressure of arterial oxygen, you get it from the blood gas, and the partial pressure of alveolar oxygen is the formula is this, is the atmospheric pressure minus the water pressure in the lung at 37 degrees centigrade. So that's why I try to keep the humidity nearby 36 or 37 when you are using CPAP or high flow, because our normal alveoli humidity is about 37 degrees centigrade. So atmospheric pressure is about 760, and the water pressure is about 47. So 716 minus 47 is come to 713. FiO2, whatever the FiO2 on the baby, minus PaC2 from the blood gas, divided by the respiratory quotient, which is 0.8, and sometimes they use 1, but mostly they are using 0.8. So this is the thing you know how to calculate it. The stages of lobar pneumonia is the same as in the bigger children or the adult, the congestion, which is JN1, 2, so parenchymal partially the consolidation. So that's why in day 1 and 2, mostly in the premature babies, it looks like same as the RDS picture. Alveolar lumens with serous exudates, bacteria are rare in inflammatory cells is the microscopic finding. Then come to the red hepatization, which is 3 to 4 days of life, and then you can see the consolidation or the real picture of the pneumonia. Alveolar lumens with exudate rich in fibrin is the main problem in the microscopic finding. Then in the gray hepatization, which is 5 to 7 days, is uniformly gray, which is a very big patch. Typical pictures of the X-ray alveolar walls are thickening. Okay, and the resolution is day 8 to week 4, gradual aeration of affected segment, and enzymatic fibrinolysis. Macrophages remove the separative exudate. So that's how this process is evolving in the neonatal pneumonia. So this is the same diagram which I just mentioned. So now come to the physical examination. Pulmonary findings. I told you that main thing is tachypnea, which is respiratory rate more than 60 per minute, plus anything, expiratory grunting, respiratory muscle recruitment, retractions, nasal flaring, anything you can add up into that. Lot of airway secretions. This is also one of the things. So if the baby has a lot of airway secretion, you think of the T fistula or something like that, but you pass the OG NG tube and you find it out. It is not, but then if they have a lot of airway secretion with this tachypnea, make sure your X-ray and the baby is doing well, because it can be the caused by the inflammation. Cyanosis, and is the 5 gram per deciliter of deoxyhemoglobin. Increased respiratory support requirement. If, for example, if the baby come initially fine, then you need a high flow, then you need a flow, then you need a CPAP. It is also indication of that. They also manifest with the asymmetry of the breath sound and the chest excursions, which is suggests air leak or emphysematous changes. And this is also, you can have it in the pneumonia. I think I mentioned this in one of my talk, but again, it is important to differentiate between tachypnea versus respiratory distress. Normal respiratory rate, most of the time in many of these studies published, is 40 to 60 per minute. Tachypnea is anything more than respiratory rate of 60 in a quiet resting baby. If a baby is a quiet, resting, no other sign and symptom as only tachypnea, then it is only tachypnea. Distress can be with the tachypnea, which is respiratory rate more than 60 or maybe less than 60 with retractions, grunting, central cyanosis, lethargy, and poor feeling. So both can happen, tachypnea alone and the respiratory distress, or both together. You have to know what is the difference between respiratory distress versus respiratory failure, so you will act very swiftly. The clinical definitions are type 1 respiratory failure when the hypoxaemia, when your blood gas PaO2 shows less than 60 mmHg. I'm talking about arterial. Whenever we give the values, we talk about the arterial blood gas. We don't talk about the VBGs or the CBGs. Type 2 hypercapnia, if the PCO2 more than 50 mmHg, usually with pH of less than 7.35. If your center don't have the blood gas, then go by the sign and symptom which I just mentioned to you. Okay, the sign and symptoms can be again like sepsis from anywhere to anywhere. Temperature instability to oliguria, anything can happen. Localized finding, for example, if the baby are doing with the torch infection, okay, they can have a conjunctivitis, they can have unusual nasal secretion, they can have erythema, swelling, growth, unusual drainage. So many things can happen, and you have to see and assess the baby again and again and figure it out that where it is the baby is going. Is only the respiratory distress or is it a real pneumonia? There's one study by the Timothy Duke in neonatal pneumonia in developing countries, published in Archive Disease Child Fetal Neonatal edition. Is a very recent study. And what he suggests that sensitivity percentage-wise of a clinical science for radiographically diagnosed pneumonia in neonates in developing countries. He took 3 major studies and they found it out the chest recession in 84% of their babies in one, 91% of another baby, and 36% of another baby. Tachypnea is almost 89% in one study, 72% and 60%. Fever is 56 and 30%. Inability to feed is about 50% in all the studies. Cyanosis is less in one study, but the other study show 39 to 40. And they are also having cough in their study. The next thing is the role of hypoxaemia and neonatal pneumonia. So what they found it out in the similar study that 38.5% of infant under 2 months of age of presenting to a tertiary hospital emergency department in India, saturation 90, and in 43% of neonates admitted to provincial hospital in Papua New Guinea is about 86%, more than 2 standard deviation below the population mean. And they found it out respiratory rate within the normal range of 30 to 60 breaths per minute. So they have the hypoxemia, but the respiratory rate is below or normal. Incidence of hypoxemia of 10% in primary care facilities and more than 30% of the hospital at the referral hospital when they don't have the availability of oxygen, similar to conditions which we have in our country. They combine many information like that, and they develop a risk factor for death. And what they found it out is risk factor for death from the neonatal pneumonia are early onset disease. If the baby has this disease from the day one, then the chances of the risk factor for the death is high. Hypoxemia, low birth weight, and absence of tachypnea. This is very interesting to know. So what they found in these three studies, that number in the relative risk range who died, total number in the relative risk range is the case fatality rate, which is CFR. So in one study, tachypnea more than 60 or the 60 breath per minute is 30% die, 5% in this and 21%. But if 50 to 60% is 20% in this study, but 58% in this study. Similar result if the breaths are less than 50 in two studies is 57% and 27%. So I think the pathogenesis of this, that tachypnea is the way the baby try to help himself or herself to breathe and to ventilate and to oxygenate himself. But if the baby cannot do that, and that the tachypnea converted into the normal or the bradypnea, so the protective effect of tachypnea will gone, and the baby, the chances of the risk factor for the death is high. So be careful if you have a baby with hypoxemia, with signs and symptoms, and no tachypnea. Be careful, and you don't neglect, don't underestimate this baby. Now, differential diagnosis is easy. You all know better than me. It's a preterm pathology, term pathology, congenital anomalies, and non-respiratory, which all can be present according is the same, but the preterm and the term pathology can also have the pneumonia in both ways. So we don't have to go through it again. Now, the important thing is radiology, how you diagnose it. So the labs and the radiology of the pneumonia. We know that we are not the radiologists, but I think we should develop our skills to read our own X-rays. To have the luxury of pediatric radiologists is very, very minuscule in all part of the world, okay? So what we should look into it is costophrenic angles, pleural space, diaphragmatic margins, cardiothymic silhouette, pulmonary vasculature, right major fissure, bronchograms, lung expansion, and patterns of aeration. So we should all look into it. Radiologically, the diseases in the neonatal period is divided into three categories: diffuse neonatal lung disorders, in preterm like surfactant deficiency, okay, in full term like retained fetal fluid, which is TTN, transitory of the newborn, meconium aspiration, diffuse developmental disorder, congenital surfactant dysfunction disorder, or pulmonary lymphangiectasia. And in both preterm and full term is alveolar growth disorders or vascular congestion or the cardiac disease. Focal neonatal lung disorders are the congenital overinflation, congenital pulmonary airway malformation, and bronchopulmonary respiration. Diffuse or focal neonatal lung disorders can be neonatal pneumonia, pulmonary interstitial emphysema, aspiration due to the congenital anomaly. So all these are divided according to the our radiological findings. There's an interesting in an old study, and they found it out that what can we look into radiographic findings in the neonatal pneumonia? What are the most evident findings? And they found it out the alveolar densities, which is about 77% of the cases. Air bronchograms is about 50% of the cases, and pulmonary interstitial emphysema is about 23% of the cases, and all others are listed here. So we should know the alveolar densities are the main thing which we should look into it. So if you see this X-ray, it looks like the typical premature lung. But this is the X-ray of 38-weeker, almost term baby or early term baby. And what the alveolar densities which we are talking about are these, these are not, I don't know if it is very clear or not, because I am putting in the PowerPoint and then you are seeing in the Zoom. But anyway, I will put this presentation on the main academic group so you can appreciate better. So these are the, not the PIE, these are the alveolar densities in early stage. And as you can see here, it's not diffuse. So it is not be the premature respiratory distress syndrome. If you see the more clear picture, you can see here. Okay. And here the lungs are much better as compared to this side. So this is one of the way that the radiological difference between the respiratory distress syndrome and the pneumonia. The other way is the associated syndrome. So for example, if you get a premature baby with this X-ray, definitely everybody said this is the respiratory distress syndrome, and you cannot differentiate with the lungs. Yes, with the pneumonia, sorry. But if you can see, this is the picture, they took it, they intubate within 1 hour. And look at this. It is very rare that to have this picture like a pulmonary interstitial emphysema to develop within 1 hour of intubation or within 1 hour of the day of the life. So then it can goes more in favor of pneumonia as compared to the RDS. Other than that, if you have this type of picture, of course, this is very clearly seen is the patchy or the streaky involvement of the lungs. And this is also is a very typical picture that you cannot miss it, that it is the very typical pneumonia picture. So having said that, I just want to tell all of you that with the X-ray, try to build your skills, see different X-rays, discuss with your radiologist, then you can able to see what you want to see, okay? It is not that difficult. So this is about the radiology. I explained to you this, if you have an ultrasound machine in your unit, and if you have a linear probe, please learn how to do lung ultrasound. This is very easy techniques. I learned recently, I am practicing it, and it can give you, without radiation, a lot of information. You can have it about the RDS, you can have it about the pneumonia, and so on and so forth. I think I explained this in my RDS talk also. Again, it looks like this. These are the ribs. These are the two horizontal lines called A line. If all the ribs are there, but the horizontal lines are missing, this is consolidation. Similarly here, okay? And this is like a hepatization. As you can see, this is the liver, and this is the same texture like a liver. There is another lines with the another placement of the probe, which is called the B lines, and it looks like this. So this is the rib, and this is the B lines. But if you have obscured, either it is the consolidation or the fluid, or it should like it looks like that here also. So all these is a very handy technique to do it. You can learn it very easily. So if you have linear probe and the ultrasound machine, please try to learn ultrasound of the lung. Now come to the labs. everybody favorite. Complete blood count as usual, same 5,000 to 25,000. Inflammation marker, CRP, procalcitonin, cytokines, whatever is available. Cultures, you have to do it. Arterial blood gas is available if you have to do it. But the controversy is about the endotracheal aspiration. By the way, we are not doing endotracheal aspiration, but there is one study which I put it in the bold. They said that at least that the within 8 hours of birth, if you take the endotracheal aspirate, it correlate very well with the blood culture results and probably reflect aspirated infected fluid or something like that. But most of the time we are not doing it because yes, if the baby is intubated for a long period of time, then we have to take it to find it out it is colonized with some bacteria or some invasive bacteria. But usually we are not doing it, but still there are some centers who are doing the endotracheal aspiration if the babies get intubated within 8 hours of the life. Cultures from the other side is still in fashion, BAL, culture of the pleural fluid, but we don't recommend, don't do it, just make it simple. Extrapulmonary lesions also, if you have it, but just for your information, I put this in the slide, but otherwise it is not recommended. Urine culture, you should do it because during the first 3 days of the life, after the first 3 days of the life, because the first 3 days of the life, urine culture is unlikely to be helpful because most of the urine tract by the hematogenous. So you already sending the blood culture. So after 3 days of life, you should do the urine culture. Again, your favorites, marker of inflammation. Dr. Huff talk about it a little bit. I talk about it. It's a controversy. Yes, you have to do it, but I put it in the red and the bold, and I am reading as it is. These tests may be useful in assessing the resolution of an inflammatory process, including infection, but they are not sufficiently precise to establish a diagnosis without additional supporting information. So CRP 40, CRP 30, CRP 20, it is not alone sufficient. Decision about antimicrobial therapy should not be based on inflammatory markers alone. Please make sure of it. So many times the people are doing that the CRP come down very nicely, the baby recover very nicely, you completed the 7 to 10 days of antibiotic, and before discharge, I want to do the CRP. Why you want to do the CRP? Because if that CRP come 20, then what you will do? You will treat that patient, which is normal, absolutely fine, and everything is okay. What the information it gets. So the alone this CRP or the procalcitonin or the cytokine or any inflammatory marker which you are working with is not enough. So it is, yes, good information how your treatment progress or how your kid is doing. So this is one of the things you have to understand. Now come to the treatment. So therapy, of course, is multifaceted because we have to address many issues. Our goals are eradicate the infection. Even if we eradicate the infection, it can have the long-lasting permanent pulmonary changes that adversely affect the lung function, quality of life sometime, and susceptibility to later infections. So this is keep in your mind. Antimicrobial, of course, these are the thing, and they are the same as we are using in our neonatal sepsis. Of course, parenteral route is preferred. Why I put it in the red? I will come to one point just after this. Endotracheal aspirates are not considered. It most of the time is the colonization, so we don't worry about that. The duration, what we are using, it depends on the baby, but we are using minimum of 7 and maximum of 10 days for the uh, pneumonia, and it depends how the baby is doing. If the baby have a viral with the central nervous system involvement, then of course we talk about it in our antibiotic duration. In sepsis, it's about 21 days. So the doses are different. We are using penicillin and gentamicin combination. So if the gestational age is less than 35, postnatal age less than 7 days, then this is the penicillin dose. Alternative, many people using ampicillin. If more than 35 and less than 7 days, this is the dose. And this is the penicillin dose if more than 7 days. And this is the postnatal age more than 7 days. If more than 35 weeks, this is the dose. The duration of therapy, the 7 to 10 days, is not only the 10 days, but this is this is the same what we are doing. And this is the recommendation from the AAP also. Respiratory support, if we suspect the respiratory distress from the birth, whether it is respiratory distress or infection or pneumonia, we start with the CPAP. CPAP, CPAP, and CPAP. CPAP is the gold standard for respiratory support if you want to do it. Okay. Airway patency, gentle vibration percussion, or the physiotherapy, all this come later on. Some people use the mucolytic agents, but we rarely, unless until the baby get chronically ventilated, then we use it, but otherwise we don't. Ventilatory support nowadays is less and less and less because the CPAP is working very fine in all those conditions, and they are doing perfectly. So ventilatory support is not that often we are using. Similarly, the people are also thinking of high frequency if the baby is very much tired and retaining PCO2, but data are sparse, and it's up to you what is the condition of the baby and the availability of the high frequency. Another point which I want to mention that if the baby has meconium aspiration and you find in the chest X-ray there is a meconium aspiration, then you should give the surfactant. And also there's one recommendation, it is from the American Academy of Pediatrics, that if the baby has a group B streptococcus pneumonia, or you think of because the mother is GBS positive or all these things, then you should also use the surfactant. So surfactant can be used plus minus, it depends according to your baby, that how it is doing. But again, initially, even with meconium aspiration, even with pneumonia, even with these things, respiratory distress syndrome, start with the CPAP and see how the baby progress. Okay. Other cares is also important. If the baby is really sick, you have to maintain about 13 to 16 grams per deciliter of the hemoglobin. And if you are very much suspect and very much thinking of pneumonia, then it is very important. Okay, it is not the same value what we are discussing for the anemia of prematurity. That's a total different ball game. Here we are considering the optimal oxygen delivery to the tissues. So around 13 to 16, depend if the baby is big, then it is about 15, 16 is you should maintain it. Delivery of of course, the other thing, the glucose, thermoregulation, electrolytes, and other neonatal supportive care should be there. Nutrition is very essential. You have to start, if the baby is tachypneic, then you should put the NG tube and start feed. If your facility is not capable, then try to transfer as soon as possible into the higher end unit. So remember, I told you that I put it in the red. The preferred route is the IV. We all know that. But this is the two very landmark articles, one from Pakistan and one from the other countries, the community-based recognition and treatment. So this is the meta-analysis of 5 studies of community-based trials from India, Pakistan, Bangladesh, Tanzania, and Nepal showed a pooled reduction in mortality of 27% and a reduction in pneumonia mortality of 42%. What they did, that antibiotic use in these studies is oral cotrimoxazole for 5 days, or procaine penicillin, or oral ampicillin. And they find it out because there is no facility to admit those patients. They are in the interior of the country, rural areas. So what they said that we have to support somehow, and they found it out that this reduced the mortality. So the similar study we are talking about in our group about the prevention is a study done by Dr. Zaidi and Dr. Zulfikar Bhutta in 2011 in association with UNICEF uh, through the from the AHAM. The background of this study is effect of cases management of neonatal mortality due to sepsis and pneumonia. And the background is each year almost 1 million newborns die from infection. Timely case management would save many lives. So the timely case management is the key to this study. And they have estimated the effect of providing oral or injectable antibiotics at home. So what is the definitions of interventions they reviewed? Oral antibiotic therapy alone, which is administer of oral antibiotics in the community for neonatal sepsis. I know I'm getting some much time, but I will inshallah finish as soon as possible. Administration of oral antibiotic in the community for neonatal sepsis, meningitis or pneumonia. Injection therapy alone, administration of IM antibiotic at home or in first level facility for neonatal sepsis, meningitis, pneumonia, or hospital-based, which we all know. So they collect the data, they collect from the many studies. The final study, the final study 7 reported in 8 papers, oral antibiotic reduced the mortality. The final studies abstracted from hospital-based case management reduced the mortality by 55. So what are the effects they find it out? They found it out that the all-case mortality 0.75 and pneumonia specific is reduced by using the community-based oral antibiotics, which is very interesting and very nice to learn, because then we can help many of our babies in interior of the country or the rural areas. There are 4 major studies. They look into it, one from Nepal, one from Tanzania, one from Pakistan, one from India. And what they found it out that the relative risk of pneumonia specific neonatal mortality rate is reduced in these areas. So the all-cause mortality is reduced, and outcome of the pneumonia mortality is also reduced by doing this. So they conclude that oral antibiotic administered in the community care in the community are the effective for neonatal pneumonia mortality reduction based on meta-analysis, which I just showed you. But the expert opinion suggests much higher impact from the injectable antibiotics, and we all know that. And this is the Delphi scores. This is the Delphi expert opinion. When we do the statistics, I will explain all. Naveed or Nasir will explain to you what is the meaning, but look at into that the mortality reduction in the injectable is higher, much higher, but than the oral. We all know that, but still the mortality is reduced even by the giving the oral antibiotics. So this is the point. Despite feasibility and low cost, these interventions are not widely available in many low-income countries, and same related to our country also. So these interventions hold great potential to reduce the 1 million neonatal deaths each year. So that's they conclude that, and so the work in the community-based and to just to let them know the doctors there or the nurses there, they can offer big help to reduce the neonatal mortality by sepsis and pneumonia. So these are the complications you all know better than me of the pneumonia: pleural effusion, infected pleural effusion, empyema, hypoperfusion, and all those. I don't have to go through it. Now the prevention, I told you that prevention, of course, we discussed that better than cure. There are 3 measures which is shown to be effective in many studies. Active management of preterm rupture of the membrane, whatever the policies or the protocol you have, you should stick to that. Promotion of the basic newborn care in the communities, which I just talked about, that if we develop the community-based services, this is the sure shot. effective in decreasing the infection and the sepsis in the communities and prevention of nosocomial pneumonia, which we all talk about. But there are some more things which we are, which we can further investigate. One is, again, in the low-income countries, is maternal immunization during the pregnancy with an pneumococcal polysaccharide vaccine. And they use it in the Philippines, Papua New Guinea, Bangladesh, and the Gambia. Antibodies are acquired through both the maternal fetal circulation and after the delivery through the breast milk. And they found it out that 25% of the neonatal pneumonia in those countries due to pneumococcus, even protection in the first few months of life may be extremely beneficial. And they found it out is beneficial, but of course it has to be explored further. This is one thing. In Africa, in Malawi, what they are doing, that they try to clean the birth canal with 0.25% chlorhexidine at every vaginal examination before delivery was associated with a lower rate of the admission for the neonatal sepsis and lower the mortality. So I'm just giving you these ideas just to develop your own ideas, and small ideas like these, it can help. Interesting to me is the third one, which is the vitamin A supplementation at birth. The two large randomized trials shown that the vitamin A supplementation at birth reduced young infant mortality. 24,000 international vitamin A on day 1 and day 2 of life in India resulted in 22% reduction in total mortality at 6 months of age. And in Indonesia, newborn, the risk of the death was 64% lower, and the incidence of cough and fever was significantly lower in the first 4 months in those who were given 50,000 international unit at first day of life. Again, it is another area to be looking into it, and then if we can reduce the mortality and infection. So the conclusion is, sorry, I took too much time, but anyway, the conclusion is the global burden of neonatal pneumonia is huge. Efficient intervention must be targeted at all levels of health services and communities. Unlike for pneumonia in older children, where effective intervention against staph pneumo and H influenza will substantially reduce disease prevalence, the etiology of neonatal pneumonia is more complex, as I told you, in pathophysiology and everything. Intervention that will reduce the mortality from neonatal pneumonia is broad-based, which include the maternal health, better management of the other common neonatal condition, reduce long-term childhood and adult morbidities in the mothers, rising rates of resistance to avoid affordable antibiotic may mean that CFR, the case fatality rate from neonatal pneumonia will increase in developing countries. So emphasize the need to explore widely applicable preventive and treatment measures. So this, how we can control this whole disease and the infections and decrease our mortality rate.